A very good afternoon, sir. I am your host for the day. My name is Shweta, and we are here live from the International Hall B. And without any ado, we are already running a little late. Let's start with our first speaker. Our first speaker for the day. You can proceed, sir.
Okay, thank you very much. Our moderator will be changed to today by Dr. Jeremy Koch. So maybe Jeremy.
So maybe I shall introduce the speakers that are speaking before they start. So our first speaker, thank you so much for inviting us to this event, to this session. We're very welcome to come and share our experience. So our first speaker is Dr. Yip Pui Pui. She's currently the president of the Hong Kong Ophthalmological Society. Dr. Yip is also the honorary clinical assistant professor of the Department of Ophthalmology and Visual Sciences in the Chinese University of Hong Kong, and also an honorary consultant in the Hong Kong Eye Hospital. She is also the director of the Champion Eye and Refractive Surgery Center in private practice. She is an advisory board member in the Chinese University Hong Kong Jockey Club of Ophthalmic Microsurgical Training Program and is an instructor at the CUHK Advanced Ophthalmic Training and Education Center. She specializes in retinal research with interest in surgical retinal cases, age-related macular degeneration, and diabetic eye diseases. She has authorships in over 50 features articles and is greatly involved in numerous international ophthalmological conferences and training workshops. Her lecture title is to help us introduce the HKOS, the Hong Kong Ophthalmological Society, and some. Dr. Yip.
Okay, thank you, Dr. Kwok. Good afternoon, ladies and gentlemen. I'm Dr. Yip Pui Pui, current president of the Hong Kong Ophthalmological Society. On behalf of our society, we sincerely thank All India Ophthalmological Society organizing the 79th annual conference and inviting us to give this talk at virtual platform. Nice to meet you all. First of all, I would like to give a brief introduction about our society. Here is our current council, which consists of 18 council members. The Hong Kong Ophthalmological Society was founded in 1954 and is now in its 67th year. We are committed to uphold a high professional standard of ophthalmic practice and increase public awareness of common and sight-threatening eye diseases in our community. We are established to foster brotherhood and sisterhood among eye care professionals in Hong Kong. Hong Kong OS is the earliest ophthalmic professional bodies established in Hong Kong. And currently, we have more than 400 members representing most of the ophthalmologists actively practicing in Hong Kong. Hong Kong OS has positioned itself as the core that binds all of us in the field of eye care. The societies always strive to provide platform for continuous medical education locally and internationally. Our society hosts the 9th Congress of Asia Pacific Academy of Ophthalmology in 1983 with great success. And in 2008, the World Ophthalmology Congress, co-hosted by International Council of Ophthalmology, was well attended as well. The latest one was in 2019. Our 33rd annual scientific meeting was successfully held in conjunction with the Greater Bay Ophthalmology Conference. The main goal of our society is to maintain and improve the quality of eye care in Hong Kong. We regularly organize public eye education campaigns, health talks, screening programs to raise the public awareness of the importance of eye health. Here is the list of public eye education campaigns over the past 20 years. Recent screening programs, including screening for myopia, glaucoma, diabetic retinopathy, and age-related macular degeneration. Since 2020, we started online public education and social media channel as well. You can find more information about our society at this website. Looking into the future, Our society will continue to serve as a window of international collaboration, as well as a bridge for members from different sectors of ophthalmology. Please feel free to contact us. Let's start our academic symposium on myopia. Myopia is a fast becoming a global health burden, particularly in developed countries. Globally, the prevalence of myopia and high myopia is 28.3% and 4% respectively. These numbers are estimated to increase to 49% for myopia and 9.8% for high myopia by 2050. This myopia boom is also found in Hong Kong. 60 years ago, only 10 to 20% of Chinese population was myopic. But today, up to 90% of teenagers and young adults are, especially in university, are myopic in Hong Kong. In 2020, according to Hong Kong Children Eye Studies, 13% of 6-year-old children are myopic. They are in primary year 1. As observed in here, every 1 year up, there will be 10% increase of prevalence of myopia in primary school children. Therefore, at primary 2, there is about more than 20%. In primary 3, that is about 8-year-old, there will be about 30%. And in all the primary school children, almost 40% are myopic. More terrifying is nearly 95% of university students are myopic with an average of -3 diopter. You can imagine how huge the problem is if everyone in the hall of now sitting here are myopic, and we also need to face its related complications. In this table, you can see the odds ratios of myopia-related complications, namely myopic macular degeneration, retinal detachment, cataract, and glaucoma. These odds ratios compares different degree of myopia with that of ametropia. You can see that the odds ratio for myopic macular degeneration in no myopia is in teens, but it will increase to more than 800 in patients who got high myopia. And this dramatic increase is alarming. And for retinal detachment, the odds ratio for low myopia is about 3-fold, but in high myopia is about 12-fold. And for the cataract and open-angle glaucoma, the odds ratios will be increased for about around double when compared from low myopia to high myopia. And these severe cases indeed may lead to permanent loss of sight.
It's always nice to see you.
Let's now pass to my colleagues to discuss further in depth about myopia management, especially on its genetic and myopia-related complications. I would like to take this opportunity to acknowledge my counselor, Dr. Jason Yam, and the teamwork of Chinese University of Hong Kong, who have performed the Hong Kong Children Eye Studies. I would like to end my presentation here. Thank you, Dr. Kwok.
Thank you very much. Yeah, thank you, Dr. Yip, very much. So I think we can have some questions, and if it seems like there is participant-wise, it's mostly a lot of the panelists and also the speakers. But if there is any questions, we can also have a discussion in regards to the topic.
So can we request you to take all the questions at the end of the discussion, once every speaker is done with their presentation?
Oh, sure.
Thank you.
Okay. So shall we proceed
Proceed with the presentations.
the second presentation?
Yeah.
I think
Meanwhile,
we have,
all the attendees, it's a request. If any questions, you can just use the Q&A tab, which is mentioned below, and you can submit all your questions there. We can answer it at the end of the session. Thank you.
let's see. Okay. Maybe I shall also introduce the second speaker before Dr. Guy Chen speaks. Dr. Guy Chen is our second speaker. As we can see, his topic is on genetics of myopia and myopia progression in Hong Kong children. Dr. Chen is a associate professor and also the head of graduate division in the Department of Ophthalmology and Visual Sciences in the Chinese University of Hong Kong. He's also the honorary associate consultant in the New Territory East Clusters of Hong Kong. Dr. Chen subspecializes in vitro retina diseases. His major research diseases, including macular and retinal diseases. He's also working on the genetic profiling of myopia progression in children. Dr. Chen and his co-workers have identified a large number of new disease genes, loci, and new mutations and new association profiles and biomarkers in major eye diseases. He has published over 125 papers in international peer-reviewed journals and delivered and chaired more than 40 sessions and international conferences. So thank you very much, Dr. Chen, for your presentation.
Yeah. Thank you, Jeremy. Can you hear me, please?
Yes, we can hear you very well.
Okay, great. Thank you. So good afternoon, dear friends and colleagues. First of all, I would like to thank for your kind invitation to us. And I'm Guy Chen from the Chinese University of Hong Kong. And today I would like to share with you our work on myopia genetics and in Hong Kong Chinese, especially in children. These are my research funding related, and I have no commercial interest. As Pui Pui mentioned just now, that myopia usually result from the elongation of the eyeball, leading to blurred distant images. And it is one of the most common eye disorders all over the world, especially in Asia. While in Hong Kong, as Pui Pui mentioned just now, according to our latest study, myopia occurs in a large proportion of children, and over 90% of the university students are myopic, with 30% of them having high myopia. You know that high myopia is associated with a number of blinding complications, and therefore, with the high and increasing frequency of myopia, along with its blinding complications, we want to study myopia, of which, however, the causes and prevention methods has not been fully defined. Currently, some major environment risk factors have been identified for myopia, including reduced outdoor activities and increased linear work. Also, parental background also increased the risk of myopia, suggesting that genetic factors may also play a role. In fact, myopia is a complex disease resulting from the interaction of multiple genetic and environmental risk factors. Regarding the genetic models, there are Mendelian form and complex form of myopia. Based on different genetic patterns, we can adopt different approaches to identify the genetic factors of myopia, including the hypothesis-based approaches and also the hypothesis-free approaches, as listed here. As early as the 1990s, the first linkage locus of myopia had been identified, and so far, more than 20 linkage loci have been found. In a recent large-scale genome-wide association study, over 400 genetic loci have been identified. They collectively explain over 18% of the heritability of myopia, suggesting that there's still a large room for us to look for new myopic genes. Our group has been working on myopia for years in Chinese, and in earlier years, we mainly work on adult myopia. We conducted linkage analysis and identified new loci for myopia. Also, we conducted GWAS and identified a number of new genes and SNPs for high myopia in Chinese. And in this work, we identified 2 new genes. While in this GWAS, we identified another new gene, the ZFX1B gene. By working together with the CREAM consortium, we have identified a number of other new genes and loci for refractive error and myopia. However, this gene was mainly targeted on high myopia, but we wanted to determine the roles of those genes in different severities of myopia. Therefore, we conducted the candidate SNP analysis in different grades of myopia, and we found that most of the genes were associated with higher grade myopia. These genes can be risk factors for myopia progression. However, we cannot test this hypothesis in adults. We therefore proceeded to work on myopia in children. There are a number of advantages in working on children, and the most important one could be that with the refractive error in children is still progressing. Therefore, we will be able to identify genes for myopia progression. Moreover, once we identify genes for ocular trace in children, we may be able to identify genes for eye diseases in an earlier age, facilitating us to earlier intervention. Hence, since 2015, we have been conducting the Hong Kong Children Eye Study, and up to now, we have screened and recruited over 35,000 children and their parents with the DNA samples collected for genetic analysis. We first identified that SNPs in the Win7b and RSPO1 genes were associated with Exo-Length in children. And then we find that the ZC2H11B and BICC1 genes were associated mainly with the moderate and high myopia in children. Collectively, these findings may suggest that certain genes are associated with higher grade of myopia, indicating that they may be risk factors for myopia progression. When reviewing the literature, there was only one article about the genetics of myopia progression in children, which was reported more than 10 years ago by Professor Saw's group from Singapore. Therefore, we conducted a longitudinal study to investigate the new genetic markers for myopia progression in children. We recruited the subjects from the Hong Kong Children Eye Study, and we performed psychoplegic refraction. In this study, we performed psychoplegic refraction for all children and collected their blood or buccal swab samples. Also, we collected detailed demographic and lifestyle data using detailed questionnaires. We followed up the children for 3 years, and this study involved over 1,000 children who have completed the 3-year follow-up. We selected SNPs from our previous studies and also the MET SNP from a Singaporean study. Here are the demographic data of the subjects. They are comparable to the overall subjects in the Hong Kong Children Eye Study, suggesting that the cohort is representative. We find that 2 SNPs in the GJD2 and KCNQ5 genes were associated with fast myopia progression, and in contrast, the MET gene, which was reported by the Singapore group, was not associated with myopia progression in our cohort. We then divided the children by their progression rates and found that the GJD2 and ZFX1B genes to be associated with the fastest myopia progression. By studying the progression of the spherical equivalent and also the Exo-Length, these genes are also associated with a positive. These genes also showed a positive association. We then investigate whether the genes have additive effects by using polygenic risk scores, and find that children having the highest score may have nearly 2-fold of increased risk of fast myopia progression. So in conclusion, this study identified 3 new genes as genetic risk factors for myopia progression in children. Their effect may be exerted via the axial elongation. Therefore, additional attention and proper intervention should be given to those children who carry the risk alleles of these genes. And this finding has been published in BJO recently. Apart from candidate gene analysis, we have also conducted GWAS on different children eye traits. And also in our previous clinical trial, we have identified low-dose atropine was effective in controlling myopia progression in children. And we have done a GWAS on those children samples, and identify 10 SNPs to be suggestively associated with myopia progression in children. And we are now validating these results, and we hope that we can share with you the updated results in our next international meeting. So finally, I would like to thank my team and colleagues we work very close to fight myopia, and also with a hope to identify new markers for myopia for early intervention. And also, I would like to also thank our colleagues in our society and also our college for all your support, and we join hands to fight myopia and in Hong Kong and all over the world. And finally, thank you very much for your attention. Thank you.
Thank you very much, Dr. Chan, for your presentation. So we'll continue with our next presentation before we go to questions. The next presenter is Dr. Tommy Chan. He's currently a specialist in ophthalmology in the Hong Kong Sanatorium Hospital. He is also the clinical assistant professor, honorary clinical assistant professor in the Chinese University and also the Hong Kong University. He has published over 130 journal articles and book chapters and has delivered over 100 talks locally and internationally. His special interests include corneal refractive procedures, cataract surgery, keratoconus management, and anterior segment imaging. He has been elected and won multiple awards, such as the Distinguished Young Fellow from the College of Ophthalmologists in Hong Kong in 2016, the Asia Pacific Association of Cataract and Refractive Surgery Film Festival Award in 2017, APAO Achievement Award, and also the Japanese Ophthalmological Society International Young Investigator Award in 2018. His talk today would be on the correction of myopic astigmatism using lenticular extraction. So thank you very much.
Thank you, Jeremy, for your kind introduction, and thank you for the All India Ophthalmological Society for the invitation of the talk. So today I will talk about some of the studies that our group have performed in Hong Kong about using SMILE, which is lenticular extraction in the correction of myopic astigmatism. As you already heard from our previous speaker, you know that myopia is very prevalent in Hong Kong, but myopic astigmatism is also very prevalent in Hong Kong. And corneal laser refractive surgery has become increasingly accepted worldwide as a safe and effective treatment for refractive error. And among all, PRK, LASIK, and SMILE are the most commonly performed refractive procedures here. And accurate astigmatic correction is essential for achieving optimal unaided vision after the surgery. And there are few studies actually evaluate astigmatic correction after SMILE using vector analysis, which is recommended for reporting astigmatic outcome. And for information, SMILE is approved by the FDA in the US for astigmatic correction up to 3 diopters since 2018. So we use vector analysis to evaluate astigmatic corrections. So what it is? So basically, we perform some calculation and evaluate the change in astigmatic axis and vectors, and we calculate the relationship among them. So, so some of the parameters that we will measure include the TIA, the target induced astigmatism vector, which is the astigmatism and the direction that we aim to correct, and the surgically induced astigmatism vector, which is the actual correction that we perform. And the differences vector is our vector difference between the TIA and SIA. And magnitude of error is the arithmetic differences between the TIA and SIA. And the angle of error is actually the angle between the SIA and the TIA. So which is the how much degree that we that is beyond planned correction. So this is the relationship showing in a diagram. And so the first study, we compare PRK versus SMILE in myopic astigmatism corrections. So in this study, we included patients with highly myopic eye, which is more than 6 diopter, and a low to moderate astigmatism, which is less than 3 diopter. So we have 34 eyes that has SMILE corrected, and 32 eyes with PRK performed. And no preoperative differences between the two in terms of the refraction. However, patient with PRK tends to have thinner cornea, and we measure the visual and refractive outcome in 1, 3, and 6 months. And for the result, all surgery uneventful. And however, for people after PRK, most of them have mild corneal haze, but most of them resolve within 3 months. And by 6 months, 97% of eye and 94% of eye are within 0.5 diopter of the attended spherical equivalent correction after SMILE and PRK. And all eyes, and only 69% of eyes are within 0.5 diopter of the intended astigmatism corrections. So you can see in here the DV, the defensive vector, and the ME is significantly lower after SMILE compared to PRK, and the absolute angle of error is wider also in the PRK. And this is the predictability graph. You can see the surgically induced astigmatism versus the TIA. You can see the green arrow here. For PRK, there is overcorrection with higher magnitude of astigmatism, but there is slightly undercorrection for the SMILE group. So in conclusion, both SMILE and PRK are observed to be safe, and the predictability was better in SMILE compared to PRK, and there are trends towards overcorrection following PRK. And this study has been published in scientific report. So, so we also compare LASIK and SMILE for correction of low to moderate astigmatism. 11 eyes with really a balance between the two groups, and there's no difference between the two groups, and we evaluate the outcome up to 3 months. And the results showed basically at 3 months, 76% of SMILE people has achieved an uncorrected distance vision of 25. And however, there are more eyes, 95% of eyes attaining a 25 visions. And in terms of astigmatic correction, 97% of the eyes after SMILE and 98% of the patient after LASIK has 0.5 diopters of attempted cylindrical corrections. So you can see here the DV is significantly lower in LASIK group, and the absolute angle of error is also lower in the LASIK group. And you can see on the left side is there is undercorrection of astigmatism in SMILE, and on the right hand side is the LASIK, which is quite accurate. So you can see in this study, SMILE offer actually a less favorable astigmatical outcome compared to LASIK, and the angle of error is wider, and also the absolute angle error is also wider. And this study is published in the BJO. And then we try to evaluate the patient who had high myopic astigmatism correction, and which is we define at 3 diopters or more. So we have 40 eyes undergo SMILE and 65 eyes after LASIK, and there are low significant difference between the group. And we also evaluate the postoperative 3 months result. So you can see the average preoperative cylinder was minus 3.4 diopters, and similar between groups. And by 3 months, basically all eyes are able to attain in 20-25 visions, and 82.5% of eyes is more in the SMILE group, and 83% in the LASIK group attain 20/20 or more. And 90% of the eye in the SMILE group and 95% in the LASIK group actually attained within 0.5 diopter of attempted cylindrical correction at 3 months. So you can see after the vector analysis, you can see they are pretty much similar between groups. And also this is the graphic. This is the TIA versus SI versus TIA graph to show any under or over correction. They are pretty much the correction is quite good. So this is the spread of the angle of error. You can see the spread are pretty much the same, a bit wider for SMILE. And the absolute angle of error reported in the current study is around 1.88 degree at 3 months. And previous study also show a similar degree of around 2.24 degree. And also another author from India, Schezis, also show a angle of error of 2.31. So we pretty much we achieve a pretty much similar axis rotation alignment between amongst other study. And there is, mind you, that there is a trend towards better treatment alignment with higher preoperative astigmatism, and we believe that this observation could be due to the better evaluation of axis location, usually in moderate to high astigmatism. And this is also consistent with previous study. So in conclusion, SMILE offer comparable astigmatism correction to LASIK in eyes with high myopic astigmatism, and the centration and alignment of treatment is purely subjective in SMILE. So therefore, it relies on patient fixation and also the surgeon application of the suction contact glass on the eyes. And therefore, meticulous intraoperative position is very important. And this study was published in JCRS previously. And so we want to know about the learning curve of SMILE. So therefore, we evaluate patient after SMILE during the first 2 years of experience. And so for the first year, the first 100 eyes, we put it in group 1, and the late 100 eyes, we put it in group 2. There was actually no difference between the preoperative background between the two groups, and we evaluate the result up to 6 months. And for the case, there's one case of suction loss in the group 1, and also 4 cases in group 1 has tear at excision during the surgery, and only 1 case in group 2. And the efficacy index was actually better in group 2. And also at 6 months, the uncorrected vision and also the efficacy index are similar between the two groups. And in the group 1, 90% of the eyes are treated within 0.5 diopter of astigmatism corrections. But in group 2, there are actually a high percentage of eyes are attaining 0.5 diopter or at 1 week, 6 months. So you can see when we compare group 1 and group 2, the DV and also the angle of error was significantly better, lower in group 2, which is the which were the patient, the later 100 patients. So this is the graph. And so the duration of docking and also suction engagement was also different. Between groups. You can see the treatment duration was shorter for the group 2. And because if we are not familiar with the surgery, there are more manipulation, and this manipulation could lead to a slower visual recovery. And the review of literature also shows similar outcome compared to our studies. And there are more information, as I mentioned, if you have more, if the surgeon was in experience with the surgery, and difficulty in lenticular extraction will also associated with has been shown to associate with irregular cornea topography. And so apart from the easiest of lenticular extraction, patient positioning docking is also important. So in conclusion, proper treatment sensation, efficacy of docking, and such engagement is very important. And faster visual recovery and better outcome are more accurate. A profile provide more accurate and estimated outcome compared with surgical experience. So this study was published in Cornea. So I want to show further about ocular residual astigmatism. So what it is actually the astigmatism apart from the anterior surface of the cornea. So we perform some study and we compare the patient with ORA, and we find that patient with high ORA, that means the patient with more astigmatism in apart from the anterior surface of cornea show actually a worse correction of astigmatism correction. And this study actually was published as a letter in JCRS. And further on, we evaluate the efficacy of treatment the patient. So we
sorry to interrupt, sir. Yeah, the time is up. You could just conclude it within 1 minute,
yeah,
sir.
Okay, so let's I will forget about this. So basically, what we want to when we perform SMILE, we would have this preferred practice. So for planning, we will look for the amount of cylinder that we want to correct, ocular residual astigmatism, and we want to perform cornea preoperative marking, and we want to position the patient well and do cycle torsion control. And during the docking, we want to assess the angle kappa and keratometric astigmatism, which can help to improve the accuracy. And of course, for during the surgery, we want a smooth dissection and also a complete extraction. And so thank you very much for the attention. Thank you.
Thank you very much, Tommy, for the good presentation. I think if we have time at the end, maybe we can listen to a little bit of the second part of the Rush presentation. So the next presenter is Dr. Holland Lao. He is honorary clinical assistant professor at the Department of Ophthalmology and the University of Hong Kong. He's also a counselor in the Hong Kong Ophthalmological Society and is the editor-in-chief for the Eye Opener for Hong Kong. Oh, whoops, sorry, I didn't start my video. Yeah, so the next speaker is Dr. Holland Lao. So as introduced, he is the counselor, also a counselor in the Hong Kong Ophthalmological Society, and he's the editor-in-chief in the Eye Opener for Hong Kong. He specializes in glaucoma and has multiple publications and peer-reviewed journals and book chapters, and has had contribution in many international conferences. So, is he here?
Yes. Thanks, Dr. Kwok. Can you see me?
Dr. Kwok. Okay, so
can you hear me?
maybe, yeah, can you share your screen? Yeah. Yes, we can hear you. So his presentation is titled, "Is it Glaucoma? Diagnostic Dilemma in Highly Myopic Eyes." So thank you very much, Dr. Ho.
Okay, so just a moment to start. So just a moment. So can you see me? So today my presentation is on regarding the practical issues.
Excuse me, sir, please switch on camera, sir.
What?
Your camera, sir. Video.
The video? Can you see me?
Your camera, sir.
Camera?
Okay, don't worry.
We can't see your face. That's
okay. Just a moment. Just a moment. So can you see me now?
Yes.
Okay. So today can you see me and my presentation material?
We can't see your face, but we can see your presentation material.
Just a moment.
No. You have to click the video in the bottom of your screen for your Zoom. Yeah, now you're on.
Yes, but
yeah, it's okay. You can then share the screen.
Just a moment.
Oh,
so
it went away. So I don't know what happened.
Okay. So maybe
So shall we just continue without the
video? Maybe I can just continue because I'm using my iPad. So today maybe I will just talk about a practical issue. So is it glaucoma? So often we are faced with a difficulty that whether we have lots of glaucoma myopia patients here, and as well as we have a lot of glaucoma patients at the same time. Why we are concerned is that the problem of glaucoma and myopia are always linked together. They always most of the time they come in hand. As we all know that the odds of glaucoma is high in myopic eyes, and that there will be myopia causing myopia will actually cause elongation of the globe, causing structural susceptibility of the ganglion cells to mechanical stress. And there are also myopic features which are similar to glaucomatous change. And the third point is very important because we are going to deal with this from time to time. So then we are going to talk about it, how we are going to approach that. So in our traditional understanding, we start the glaucoma diagnosis by, first of all, that we know that glaucoma disease is a degenerative and progressive optic neuropathy. And then we first usually start by measuring the intraocular pressure and also examine the optic disc to look for features suggestive of glaucomatous change. And then in the earlier studies, to identify the effect of the intervention, we usually use the Humphrey visual field as a diagnostic criteria for glaucoma. So then, but each of them has some problems when we are going through myopia patients. First of all, let's start with clinical examination. So then what are the problems with optic disc? It's very difficult to delineate a cup in myopic patients, as the rim may show pallor and the cupping may be difficult to tell as the cup is flattened. And there's also disc tilting, which is more common in myopia patients. And this is very difficult in tilted discs that we try to determine the cup disc ratio. And then in addition, there may be peripapillary atrophy, which makes the delineation difficult. And then the myopic changes in terms of peripapillary atrophy is actually quite indistinguishable with those patients who are suffering from glaucoma. So this is the typical type of patients that we're facing day to day, that we have a lot of peripapillary atrophy, and that this is not really well delineated. And then it's very difficult because the cup is very shallow. Then if you first of all, if you judge by the color or by the depth, it's very difficult to delineate. So then we try to supplement the clinical examination with visual field. This is the classical diagnostic criteria in terms of glaucoma. But as we all know that nowadays, glaucoma, the functional change is always before structural changes. And then you need a significant structural change before you have some optic nerve dysfunction. So, what is the role of visual field currently? I think it is not for the initial diagnostic procedure, but then if it would be best if then we can show that there are functional changes which are correlating with structural changes. However, we all know that in real world, the life is not always easy. There will be coexisting maculopathy in myopic eyes, which will also affect the visual field. So a classical description of myopic glaucoma is that there will be early central or paracentral scotoma, but then it's not always the case. You can find something just like the textbook. So then this is one of our patients, and then if you can see that for the right eye, this is a patient referred for glaucoma suspect with increased cup-depth ratio. If you can see that there actually for the right eye, there are some early changes which are not typical, the aqueous defect, which are more like those with the central involvement, as you can see. The left eye is relatively preserved. But then if we go to the OCT, there's been already some thinning of the retinal nerve fiber layer. So then in combined risk factor and also some early functional changes, if there are some changes, I would tend to start treatment. And then maybe for the left eye, because there are some early structural changes, so I would treat that as a perimetric disease and also start treatment altogether. So then that comes the optical coherence tomography, which is our main part of for glaucoma diagnosis right now. So this is a key investigation procedure in the structural assessment of the optic nerve. So then previously we focused mainly on the neuroretinal rim, but we know that the retinal nerve fiber layer is more relevant to the glaucoma progression. So then but then optical coherence tomography has a lot of problems as involved in myopic patients. For example, for the neuroretinal rim, we know that the diagnosis is based on the Bruch's membrane opening, which may not be that clear cut in those with disrupted optic disc as in myopic patients. And then for retinal nerve fiber layer evaluation, there may be some because the eyeball is distorted. It is not that classical distribution, and then the supratemporal and infratemporal bundles will get closer temporally. And then there may be abnormal thickened retinal nerve fiber layer temporally, but thinned out inferior and superiorly. And then one of the additional problem is that we have to, the commercially available database is made essentially on those normal with relatively normal or low myopia patients. And then there's lacking of high myopia normative database for those patients. So this is a typical example of, as you can see, that of a myopic patients undergoing optical coherence tomography. As you can see that the optic disc is actually distorted. And then the picture actually pretty beautifully shows the classical features which are showed in myopia patients, so, such as the supratemporal and temporal thinning, and then there's some sort of abnormal thickening of the temporal area. So then how we are going to proceed. So in this case, in some of the cases, because of limitation in resources, then we may need to wait for some time until the features develop. But if resources are allowed, I think that one of the diagnostic clue is that we know that this is a progressive myopic, progressive optic neuropathy. So then, if with time it progresses with time, then we are more likely to conclude that it's likely to be optic. To be a case of glaucomatous changes. But then this illustrates the difficulties that we are facing when we are just faced with one cut of the optical coherence tomography. And then sometimes in view of limited resource, this is what we have within a short period of time. So, so this is the current situation about the optical coherence tomography, at least for those readily available in clinical use. So we are very concerned about whether the current modern development in terms of imaging can help, or any other modalities can help. So for laminar cribrosa imaging has been proposed for a long time that the laminar cribrosa will actually have defects which are detectable in myopic patients with glaucoma using extended depth imaging. But the problem is that this is not routinely available in commercially available types of OCT. So another hope will be the ganglion cell inner plexiform layer evaluation. This is based on the classical distribution of the optic nerve fiber layer running in a arcuate along the raphe. So then, if by in the perfect scenario, if that we can find that if the case that the optic disc is distorted and where the macula is relatively stable, then we may be able to conclude that we may be able to use the macular findings to see whether there are any glaucomatous changes. And then if best, we can, in case if the scanning around the optic disc and also the macular area concludes with each other, showing some focal defects, then we are very we are highly confident that it's likely to be a glaucomatous change. But then once again, this is not the macular imaging in terms of glaucoma diagnosis is not highly verified. And then mainly currently the current protocols is mainly for research purpose or as a supplementary information regarding in addition to the disc. So then the routine use is still limited. So another thing that we are interested in will be the vascular evaluation of the perfusion around the optic disc. And then the vessel density and choroidal thickness in the literature have been found to be reduced in myopia. And then, in addition, there will be reduced blood flow found in glaucoma. Are there any parameters to distinguish these two? And then the other thing is that the myopia is a relatively generalized defect versus focal defect. But so far, the most hopeful study based on the OCT show no additional benefit for diagnosis. So other modalities like electrophysiology may offer hope, but then you know that electrophysiology will be very difficult and will be very difficult to be performed on those patients. So another thing is that the artificial intelligence and machine learning will be maybe useful if we can combine, because this is a black box approach, which may be help to tackle about the ambiguity based on machine learning. But then this will involve a lot of time to develop a good algorithm, which may help to improve the clinical diagnosis. So I think that in conclusion, that each of the individual modalities is not perfect for diagnosing glaucoma in myopia patients. And then this actually there is a subjective arbitration involved in the present time. And then it's very difficult for us to have a objective arbitration to say whether this is glaucoma or not based on the current protocol. And then time will be another domain. And then the combination of the modalities may be the key. And then one of the things that which may help to combine that with artificial intelligence. So I think that because in limited time, I will conclude here, and then we may have a discussion later on. So thank you.
So thank you very much, Dr. Ho, for the presentation. So next, the presenter is Professor Lam Wai Ching. It's my pleasure to introduce Professor Lam Wai Ching. He's my boss, actually. Professor Lam Wai Ching is a clinical professor at the University of Hong Kong. He's also the Chief of Service of the Department of Ophthalmology in the University of Hong Kong Shenzhen Hospital and also the Queen Mary Hospital of Hong Kong. Professor Lam is a vitreoretinal surgeon with clinical interest in adults and pediatric retina diseases. For his clinical and scientific work, he received the Achievement Award from the American Academy of Ophthalmology and Asian Pacific Academy of Ophthalmology, and the Senior Honor Award from the American Society of Retinal Specialists. He is a committed medical educator and had won 16 teaching awards while serving 18 years in the University of Toronto. He has published over 100 peer-reviewed articles and book chapters, and his most recently published book is called A Quick Guide in Pediatric Retina. So today he'll be sharing about surgical management of myopic complication, macular hole associated retinal detachment. Thank you, Professor Lam.
Thank you, Jeremy, for such a kind introduction. I also want to thank Dr. Yip from the Hong Kong Ophthalmological Society and the All Indian Ophthalmic Society for the opportunity to present at this meeting. And so the title of my presentation is that of surgical management of the myopic complications, particularly in relationship to the macular hole associated retinal detachment. You already hear enough about the myopia, and you can see pathological myopia is associated with quite a number of posterior segment complications. And I'm going to highlight the last two, the myopic foveal schizis and the macular hole, because these two conditions are actually interrelated. In terms of the etiology of myopic foveal schizis, you thought that the kind of outward progressions of the posterior staphyloma as the myopia progressed, creating an outward traction or vector force, while the inner layer of the retina, such as the internal limbic membrane, epiretinal membrane, or even the vitreous on the surface, kind of taut and keeping it from migrating or moving. So these two opposing forces are creating the schistic formations of the macula. And you can see in the OCT the changes there. And when you have a macular hole, they tend to be stable in non-myopic patients, and they can be stable for months and years. On the other hand, in cases where there is high myopia, then they tangential tractions on the surface with the posterior staphyloma, as the case that we just look at the formation of schizis, it actually allows the retinal detachment to occur. In addition, you also can have tractions on the retinal vessels, and that, as in this OCT, showing the tenting effects of the inner retinal surface. The purpose of staging the foveal schizis actually is trying to figure out which particular forms of foveal schizis, myopic foveal schizis, has the higher risk of progressions. As you can see, those with the entire macular schizis or the entire macula with involved with schizis has a almost 40% progressions. So these are the group of patients that you will want to pay more attention to. What's interesting though is that once the tractions on the surface relieve, whether it is a mild degree of schizis or very severe forms of schizis, the schizis will settle. So we know that then the vitreous tractions play a very important role in the formations and the maintenance of the foveal schizis. It's important to know that immediate surgical interventions is usually not necessary with patients with macular schizis, especially among those patients that does not have any detachment or macular hole involvement. However, patients with extensive macular schizis, as we saw in the stage 4 types, a progressions to retinal detachment can occur. So a removal of those tractions is important in order to allow complete resolutions of the macular schizis. Another interesting feature that has been highlighted by one of the publications is that if you developed outer lamellar changes or outer lamellar hole formations, it is actually a risk factor for the development of retinal detachment among those patients with myopic schisis. So if you see early changes in the outer retinal layer with the separation of the outer retinal layer from the underlying RPE, this is somebody you may want to pay early attention and consider early surgery because they are at risk. Here are just comparison between a macular hole with just cystic changes at the edges with no other schitic changes. And this kind of macular hole will tend to stay stable for months and years. On the other hand, when you have schitic changes associated with macular hole, they are likely to develop into retinal detachment, and it starts because of the surface tensions or tractions that's creating the schizis. Those tractions will certainly progress and causing more separations and leading to retinal detachment. So the surgical indications highlighted here, besides being symptomatic, is if you have a macular hole with retinal detachment, or if you have even just a foveal detachment, those are one that you want to do surgery because those are the ones that will progress. The surgical goal is to remove the entire kind of inner retinal component that are consistent of the vitreous cortex, the epiretinal membrane, and the ELM, because those are the tractional force that's keeping and maintaining the separations of the schizis. And it's important to remember sometimes there's also tractions at the retinal vessels, and so those need to be attended to, otherwise they can lead to recurrent retinal detachment. Other people have suggested you might want to consider treating the posterior staphyloma. What does it mean? Well, they suggest that by using a macular buccal that will lift up the posterior staphyloma, by pushing them in, that will relieve the tractional force that's caused by the structural deformity of the posterior staphyloma. For the surgical procedure, whether it will be a foveal schisis or macular hole is essentially the same, the vitrectomy and removing the tractions. For the macular hole, some people suggest to use inverted internal limiting membrane flap, or sometimes using autologous internal limiting membrane transplantations. And when you don't have any of those membranes, you can consider using lens capsules and sometimes autologous blood to try to fill the hole. But this may not be very effective in the case of a very bolus detachment. Here I'm going to share with you a case of a bolus myopic macular hole. You can see there is a fair amount of vitreous remain and this subretinal fluid streaming through a very small macular hole. The peripheral retina was inspected. There is actually no retinal tear in there. I want to highlight here, when you try to peel away the cortical vitreous membrane on the surface in a very bolus detachment, we need a bimanual approach. You can see those are not ELM. They are actually condensed cortical vitreous. Once you have that peel, you stained the internal limiting membrane, and then that should be peeled away. This happened to be a very small macular hole, so I didn't think it's necessary to do the internal limiting membrane flapped. So again, peeling it with a single instrument is difficult when you have a very mobile bolus detachment. So a bimanual approach will be a much more effective way to peel away the internal membrane as well as the epiretinal membrane. And for this particular case, the intention is to peel the membrane completely away from the macular surface rather than trying to create a IM flap. Then the next question will come along is how you're going to drain the subretinal fluid, because if you drain it through the macular hole, there is a risk of that macular hole get enlarged. So in this case, you'll see later on that I decided to do a drainage from a extramacular retinotomy site. So a small retinotomy was created, in this case, just outside the inferior arcade. So under airflow exchange, you can see there's a tiny little hole that was created. And and most people probably would do it superiorly. That probably would be a better choice. I think there must be something there at the time that prompted me to use that site. And once the fluid is drained, then gas-air exchange was performed. Oops, we'll go to the next one. So here, showing that in some of the larger macular hole, a inverted IOM flap may be helpful to help to close the hole and finish the detachment. The surgical complication can occur, particularly in the case of macular foveal schisis. Up to 5% of the cases can develop macular hole. So that's important to recognize these complications. And usually the risk factor for that is when they have a very thin inner retinal layer in the schisis or very stretched fovea. And the macular hole with the macular detachment, the important thing is to relieve all the persistent tractions. And the closure rate with the surgery, if you completely manage the retinal tractions, is quite good, and it's about 40 to 50%. The poor prognosis factors are long axial length and poor preoperative visual acuity. Just a brief mention of macular buccal, and you can
Sorry
see
to
on
interrupt,
the
sir.
yes.
We are just up with the time, and I would just like you to conclude with the slides quickly.
I will. Yeah. So so here is the macular buccal, and it was put behind and indent the and push in the macula so that to change the vector force, and it reported about 70–80%. And here are some of the limitations for the buccal, and mostly because you require very good surgical precision in order to do that. Finally, I think the take-home messages for this management is that usually it's immediate surgical intervention for macular schisis is not necessary unless they are associated with a macular hole detachment or actually a presence of retinal detachment. And those macular hole that have retinal schisis have high likelihood of retinal detachment. Vitrectomy is the first option and has a success rate up to 70–90%. Macular buccal has a limited indications, require a good surgical skill. And thank you for your attention.
Thank you very much, Professor Lam. It's a pleasure to see your surgical videos. Without further ado, let's invite the next speaker, which is Dr. Alex Ng. He is a specialist in ophthalmology, currently in private practice in Hong Kong Ophthalmological Associates. He specializes in cornea research with over 80 publications in smile, cross-linking, ocular surface disease, cataract surgery, and myopia control. He also has over 70 invited talks, instruction courses, and participated in many conferences presentation. He had many awards previously. And even in last year, he was awarded the Japanese Ophthalmological Society International Young Investigator Award. In 2019, he was given the Asia Pacific Academy of Ophthalmology Achievement Award and multiple travel grants from ARVO in 2019 and 2015. He's also a distinguished young fellow from the Hong Kong Academy of Medicine and College of Ophthalmologists of Hong Kong in 2016. We would like to invite Dr. Alex Ng to come and help us present on the topic of low concentration atropine or orthokeratology in childhood myopia control. Thank you, Alex.
All right. Thank you, Jeremy, for the kind introduction. And thank you, Dr. Yip, for organizing the HKOS Symposium. And of course, thank you for the host for kindly inviting. I wish I could be personally in India to give this presentation. So my topic today is about low concentration atropine or orthokeratology, or what we call OK lens in childhood myopia control. Because these two options, they are basically two very common approach in controlling childhood myopia progression. And for example, in Hong Kong, both are quite popular, but the atropine are usually given by the ophthalmologist and the orthokeratology are usually by the optometrist. So obviously they have their pros and cons. So it is there is always debate whether which option should be chosen for the patient who wants to have their myopia controlled. So if you look at the data, there was a network meta-analysis published in Ophthalmology a few years back. They look at lots of different clinical trials, different spectacles, contact lenses, pharmaceutical approaches, and they found that basically the most effective ones are orthokeratology, which can give you, like, for average about 0.15 millimeters per year reduction in the exo elongation rate. And the other one is atropine. And obviously, we now all know that for atropine, the effect is concentration dependent. So if we look at the data about atropine, we are all familiar with the ATOM2 study done in Singapore. So basically, for atropine, it has a dose-dependent, concentration-dependent effect. And we all know that as for side effects, the lower the concentration, less side effects. So after that study, the 0.01% atropine has become very popular because it is effective in controlling the myopia progression, average about 50% overall. And a few years later, our colleague in Hong Kong, Dr. Yam from the Chinese University of Hong Kong, they have done the LAMP study, which look at other concentrations of atropine, including 0.01, 0.025, and 0.05%. And similarly, they found a concentration-dependent effect in myopia control. So as for the exo elongation, they found that that of 0.05% it's better than 0.01 in terms of the reduction in exo elongation rate. But obviously, from our own clinical experience, even with 0.05, some children, they do experience quite some photosensitivity and reduction in accommodation. So to summarize what I have just said, atropine on average, if we are looking at 0.01%, it slows progression by like half over 5 years. And the LAMP study also tells us that perhaps a slightly higher concentration gives you an even better effect. But from our own experience, it can come with some minor side effects. As for the orthokeratology, there are a few RCTs all concluded that around 40-ish% reduction in the exo elongation rate can be achieved. So in short, both works, but then how to choose? So as I said, each option has their pros and cons. For atropine, it is simple for most parents because it's just 1 drop per eye every night. And it can also be combined with other modalities like nowadays all those dim spectacles or like the daytime contact lenses. And the slightly downside is the light sensitivity and the reduction in accommodation that could sometimes be quite bothering to the kids. As for orthokeratology, the obvious advantage is during the daytime, they can be temporarily spectacle-free, but then it is a much more labor-intensive thing to do for both the parents and the kids. And it, of course, does carry a higher risk of infection or allergic conjunctivitis. So we always tell the parents they have to be very compliant with all the lens cleaning, etc. And obviously, not all children can tolerate putting a contact lens in during sleep. So orthokeratology, it's obviously not as widely applicable as atropine. But then in terms of the effect of myopia control, why not both? Because if you look at atropine, its mechanism, it's not well known yet, but we believe it is their action on the muscarinic receptors in the retina and the sclera. And for orthokeratology, it's mainly by reducing the peripheral hyperopic defocus because the lens changes the shape of the cornea. So by reducing the peripheral hyperopic defocus, they believe it is how they can slow down the Exo-Length elongation. So because both methods, they have different mechanism, therefore we were thinking, would there be an additive effect if we combine them? Therefore, a few years ago, we started a RCT, which was, we call it an AIOC study, the combined atropine with orthokeratology study. It was a 2-year RCT. We compare ortho-K alone versus combined ortho-K with 0.01% atropine. And for the inclusion criteria, it is basically the standard myopia control study criteria. And now today, I'm going to present our initial 12 months results. So a bit more on the methodology. It is an examiner mask RCT, and we by using previous myopia control studies, we calculated the sample size to be 60 subjects with 30 in each group. And the treatment duration is 2 years, and we actually started the recruitment in December 2016. So actually, we have now completed the study already, but we are still analyzing the 2-year data. So what I'm sharing today is the 1-year data. So it is a collaborative study between the Department of Ophthalmology of the University of Hong Kong and also the School of Optometry of the Polytechnic University, which is the institution where most RCT on ortho-K have been performed so far. So for the inclusion and exclusion criteria, it is basically following most other myopia control studies. And for the atropine, it is a preservative-free 0.01 atropine. We asked the children to put the eye drop around 10 minutes before they insert their OK lens every night. And the primary outcome, the Exo-Length elongation with IOL master. And we actually also looked at many other parameters, such as the, for example, the choroidal thickness and the higher order aberrations, which are also something that could be related to myopia control. So for the preliminary 12 months results, we had 30 subjects in the OK group and 29 subjects in the AOK group, because some patients, they drop out due to contact lens intolerance, etc. But none of our cases had any serious side effects, even with the ortho-K lens wear. So if we look at the preliminary results, this is the most important slide. At 12 months, if we look at the exo elongation, that in the ortho-K alone group, it's 0.16 millimeters. And that in the AOK, the combined treatment group, is 0.07 millimeters. And the difference is statistically significant at both time points, at 6 months and 12 months, meaning that by combining ortho-K with 0.01 atropine, we did achieve a significantly different result with the combined treatment. It is better than ortho-K alone. So, and the other very important thing is the treatment is well tolerated. As I said, no adverse events were seen in both groups. So this slide, it summarized the Exo-Length elongation data of the major myopia control studies. For example, the Yam et al. Is the LAMP study. Here it is the ATOM-1 and ATOM-2 studies. The Cho and Chang, it is the myopia, it is the ortho-K RCTs. Kinoshita is the group in Japan where they also did the combined 0.01% with ortho-K. But the protocol was a bit different. Most kids, they started with ortho-K first, and then they added the 0.01% later on. And our current study, this one, the OK group, is the control group, and this is the combined group. And you can see that over 1 year, with the combined 0.01 atropine with ortho-K, we achieved the best result in terms of slowing exo elongation. So one might ask, what is the possible mechanism of achieving this? We actually found that there was a significant negative correlation found between the exo elongation and the increase in photopic pupil size. Because we know that atropine, even for 0.01%, it does increase the pupil size a little bit. And for the effect, myopia control effect of ortho-K, we did mention that it is by reducing the peripheral hyperopic defocusing. Because the ortho-K changes the peripheral profile of the cornea. So you could think that if we are increasing the pupil size, the light ray that actually passes through the more peripheral part of the cornea will be increased, and therefore the reduction in the hyperopic peripheral defocusing would be theoretically more pronounced. So if you are, because due to the limitation of time, I'm not going to go over the details of this part, but if you are interested, feel free to look at this paper also done by our group, because we went through like our postulated mechanism of how the combined treatment give a better myopia control result. So in summary, we found that combining okay with 0.01 atropine. We did achieve the best myopia control results achievable so far, but there are still unanswered questions. For example, the optimal dosing, which concentration of atropine we should use, how long should we treat the patients, and whether there's any long-term side effects, etc. So finally, I would like to acknowledge all my co-investigators in this AOK study. So thank you very much, and I hope to see you all either in Hong Kong or in India in the future. Thank you.
Thank you very much, Alex, for the presentation. Okay, so for the last part, I'm just going to introduce a little bit of the Hong Kong Young Ophthalmologist to the AIOS and also to the Young Ophthalmologist Society. So it will be a short presentation and then we can dive into discussion. So we are established in 2016, initially as some social events of young ophthalmologists over some happy hour, but then eventually we thought that it was a good idea to start the Hong Kong Young Ophthalmologists Group. So our mission is to connect ophthalmologists in various sectors across Hong Kong, especially with young ophthalmologists, and to help budding eye surgeons become future ophthalmic leaders and to facilitate international exchange of ideas among young ophthalmologists from different nationalities. So we are a branch or a subgroup under the Hong Kong Ophthalmological Society. We have formed a young ophthalmological society, young ophthalmologist committee for governance and also for academic training, for social networking, for for public education, and for membership and internal communication. So currently these are starting this year. So during COVID, what have we done? We have tried to continue our education and workshops. Actually going on now, and 2 weeks ago is a young ophthalmologist retina workshop that was has much participation for our community across different sectors, from residents to early post fellows to a very senior ophthalmologist in the panel discussions. We also previously have done multiple webinars on basic ophthalmology investigations for our training residents, and also a review on the neuro-ophthalmology in the webinar with neuro-ophthalmology made easy not long ago. So these are the things we have done during COVID, and we have started a WhatsApp group to try to increase our connection in this time of social distancing. So we're trying to collaborate internationally. We have previously during our annual scientific meeting had a Young Ophthalmology Society Symposium, where we invited our colleagues from Singapore, from the UK, from India, and also locally to help us present. We also have represented ourselves in the AAO meet and greet for young ophthalmologist leaders. And just last week, we have been invited to join the Cake and Pie Expo to discuss about ophthalmology training, education, and practice during a pandemic with a panel discussion with multiple YO leaders. So we thank you again for the invitation, and also we welcome very much for future collaborations. So this is our HKOS website. You can contact our HKOS Secretariat for future collaborations, or you can contact me directly for any activities or collaborations with the Hong Kong Young Ophthalmology Society. So thank you very much, all the speakers. Maybe we can go into discussion and talk about, see if there are any questions from the participants and also from the panel.
Dr. Kwok?
Hello.
Yeah, hi.
Hello.
This is Dr. Joshi here from All India Ophthalmic Society. Thank you so much. It was a wonderful program to see. I have a question to Dr. Lam.
Go ahead.
Yeah. So it's a very excellent presentation by all the speakers and by you as well. But in case of myopic schizis, I had a patient recently where I operated. He was 20/40. Earlier he was 20/20, and in 3 months he became 20/40. and it was a lamellar hole. It was slightly bulged. So I did a vitrectomy, and since there was a lamellar hole or almost getting into a full thickness hole, I did a complete ILM peeling. And now he comes, he was pretty much good around 3 months, but now his vision is 2400. I again had to reoperate, going for the silicone oil, and I have subsided it now. So I feel daisy that why did I touch it? So what are your quick tips? Whether should we operate on these myopic fovea species if they had good vision?
First of all, it's very nice to see you. It's always a pleasure to meet up at your meeting. Unfortunately, we had to do it virtually, but I can't wait till we actually can meet in person in India. You have a very good question. There's actually a question we often ask when we see patients with myopic schizis, and particularly those with lamellar hole. Your patient is the perfect example. It's quite often is a bit of a dilemma. When you mentioned the patient has a visual acuity drop from 20/30 to 20/40, no question, we all raise some concern. But I think your experience tells you, and that sometimes repeated, not that infrequent, that you can develop complications from actually going in. And I wonder, I don't have any surgical study to prove that, is in those cases, whether it will be schizis or lamellar hole, perhaps a complete peeling of the IOM may not necessarily be the best options. Thinking that you have relatively good visions and to begin with. So last thing you want is to have a full thickness macular hole to develop, and that will cause a deterioration of the visions. So I would probably, and doing more often this day too myself, is to do an IOM flap. But first of all, I probably will hesitate to do surgery at 20/40 at that level still. I will have a very good discussion with the patient to have the patient understand that it's truly a risk. If the patients are very anxious and really wanted to do, then I will do an inverted IOM flap, for the reason that in case something do develop later on, I still have a very generous amount of IOM there to help me out for troubles. So that's how I would have approached it.
Thank you so much.
Yeah.
Yes, totally agree. Yes, it is a very good approach from Professor Lam. Yeah. For cases who have very thin retina and also in severe schizis cases, I think he plays a IOM flap is a good idea, actually. Yes, thank you, Professor Lam. Yeah.
Nice to see you, Dr. Joshi.
Yeah, so Dr. Lam happens to be my mentor at University of Toronto, and it's nice to see him back again in Hong Kong. Nice to see you, Dr. Lam.
Thank you.
I would like to supplement. Actually, Dr. Jeremy Quart is the current chairman of Hong Kong Young Ophthalmologists, and he done a lot on training and development for the youngsters. And he is currently also a clinical assistant professor of ophthalmology in University of Hong Kong, and his specialty interest in oculoplastic. Thank you, Dr. Quart, for chairing the session and helping us to organize this session too. And also Dr. Alex and who has been all invited and helping us to invite all the speakers and organize the very wonderful job. Thank you very much. Thank you, Professor Lam.
A hand to everybody who has done a wonderful job for this symposium.
Thank you. Thank you very much.
So I have a question for Dr. Guy Chen and maybe Alex. Just it's outside of my specialty interest, but I'm just curious about atropine and also genetics related to myopia. If there are some certain genetic profiling that maybe in the future that you can identify would give us a more insight on the dosage that can be used with atropine in children, because we have different options of atropine concentration. And I think as the presenter, as lecturer from Dr. Guy Chen, that there are some genes that would indicate a more rapid progression in the myopia in children. So I was wondering if there are any ideas or maybe concepts in the future in looking at genetics and related dosage in atropine, and how long, say, we keep the atropine for the children, and how we off the atropine eventually, would the genetic component be a huge factor in the long run of management of myopia in children?
Yeah, thank you, Jeremy. This is actually a very brilliant question and also a comment. Your point are completely reasonable and correct. That this is basically a topic of pharmacogenetics. Pharmacogenetics means the correlation between the drug response and also the genetic factors that the subject is carrying. So now, as I mentioned in my last several slides, that we in our LAMP study, as Alex mentioned just now, that we have done in the LAMP study, we have compared the effect or effectiveness of the different concentration of atropine, including the 0.01, 0.025, and also 0.05. And in fact, we have done a genome-wide association study of all of these children, about 400, right? But because we also have a placebo, and then we perform a genome-wide search of their genome, and then we basically in my second last slide that we have identified 10 SNPs. SNPs means single nucleotide polymorphisms, or gene variants, right? So we have identified 10. That 10 SNPs were we identified those SNPs by controlling the treatment groups, because we did it for several reasons. Number one is that we have only a 400 sample, so it's quite small sample size. But you know, for RCT, that this is a quite large sample already. So and to increase the power, so we have to adjust for the differences of the treatment group. So we adjust for the treatment. So we make the samples or make the data or groups. We neutralize the intergroup differences, and then we have identified 10 SNPs that are associated with the myopia progression even after controlling the infection, controlling the treatment. And then so our next step would be to conduct the pharmacogenetic study. That means that we want to identify after we confirm the SNPs associated with myopia progression. That our next step would be to identify those SNPs which are associated with different treatment responses. Just your question initially, right? So if we can identify the gene variants that are associated with better or worse treatment responses, or we probably can determine which subjects should use a higher concentration of the.
Sorry to interrupt, sir. Unfortunately, the time isn't allowing us to continue. We have another set of speakers waiting for the session to start.
Sure, thank you. So Jeremy, we have a lot of time to
we can just
discuss.
conclude it quickly, sir.
We live in the same place, so thank you. Maybe we can thank you for inviting, and thank you for everyone for participation. It's great to be on.
Yeah, thank you for your invitation and organizing this wonderful event.
Your time.
Thank you. Yeah, thank you.
Thank you, every speakers here. Thank you.